all, please join us in our quiz contest regarding critical care management.
Welcome friends. This is a very small quiz involving mostly the day-to-day critical care cases. I invite you all to this small session, which will be probably very useful for the postgraduates as well as the consultants who are practicing critical care or involved in care of ICU patients. So for this, we have prepared a set of 20 questions. Almost all the questions are clinical questions. The rule of the game is that you'll have to raise your hand and try this. There is no negative marking. And once somebody gives an answer, if it is correct, then you will go to the next question. And if it is not correct, chances will be given to the other candidates or others in the audience to raise their hands and answer this. Don't shout together at the same time. So we are going to start. Along with me, I am Dr. Joyanta Dotto, and along with me, I am from Charnak Hospital, Kolkata. And along with me, my associate is Dr. Debargo De, who will be conducting the quiz. And another doctor, we are waiting for him, Dr. Shubhan Bhattacharya, will be joining soon. So we'll go with the first question now. Over to you, Debargo.
Thank you, sir. Welcome you all. So we will start the quiz. Before starting the quiz, I would like to tell you something. Most of the questions, we will have a few options. But in some of the questions, there is no option. So I will be welcoming Dr. Shubhan Bhattacharya. So there are 2 to 3 questions where we will not get any options. So it's really a quiz type. So we will go to the first question. So this is a 52-year-old gentleman with known COPD presented with increasing shortness of breath. He was started on piperacillin, tazobactam and azithromycin, was put on NIV but developed type 2 respiratory failure, was intubated and mechanically ventilated. 4 days later, he developed a high-grade fever and increased tracheal secretions. There was also an increase in FiO2 and PEEP in ventilator, along with a rise in WBC count and CRP. Endotracheal secretions and blood cultures were sent. Antibiotics were escalated henceforth to meropenem and ticoplanin. Portable skygram of the chest showed a patch in the left lower zone, suggestive of VAP. 2 days later, the blood culture showed no growth. However, the endotracheal aspirate showed a growth of Acinetobacter baumannii with following susceptibility report. So this is our report. I will go to the next slide. So what should be the choice of antimicrobial therapy? Once more, I would like to show you the susceptibility report. So now the question. What should be the choice of antimicrobial therapy?
Your name and your answer. Dr. Anwar.
So we'll go with tigecycline with polymyxin B. TG with poly B.
Wrong answer.
Next, yes, please. Sulbactam plus.
Iodosulbactam plus polymyxin B.
Thank you. Thank you. So I'd like to.
Can you tell me the reason behind this? Why are you preferring hydrosulbactam with polymyxin?
Acinetobacter is actually the drug of choice for Acinetobacter is Iodosulbactam. And it's a multi-drug resistance, so you combine it with polymyxin.
So in the previous slide, we've shown that cefoperazone sulbactam resistance. So probably if the cefoperazone is acting, probably sulbactam is not acting on that Acinetobacter baumannii. Still you choose hydrosulbactam.
Yeah, that's why we choose high-dose sir, and also it's lung, so tigecycline penetration may not be very good.
No, actually I am just asking about the fact that the sulbactam backbone is indicated for treatment of Acinetobacter baumannii. It should not be given alone. So it should be combined with another medication. As we said that, as we show here, that the minocycline is resistant here,
So actually meropenem, imipenem, tigecycline may be sensitive, but definitely as you have said that the lung penetration of tigecycline is not that sufficient. So minocycline is resistant here. So we can use minocycline, but colistin is intermediate. As we know that there is no susceptibility shows sensitive for colistin nowadays according to the CLSI guidelines. So we can take that the colistin is sensitive here. So we should use sulbactam backbone, hydrosulbactam along with colistin. So the rationale is if you are treating Acinetobacter, you should use sulbactam, either minocycline or colistin depending upon the culture reports.
Thank you, sir. So we will go to the next question.
What are the names?
So next question is, which of the following GNBs have the least inducible AMP-C production? Enterobacter cloaca, Serratia, Citrobacter cosseri. We will move to the next question. So all of the following are components of 1 hour bundle in survival sepsis campaign except. So I will give you the opportunity here.
Measure the lactate level.
So anyone else want to try? C. Can you explain?
So exactly, just stating out of 4 options, you should explain.
Pressure to maintain. About 3 hours.
So anyone else? Okay, sir.
Lactate level, definitely yes. We have to obtain blood for cultures and we maintain the map. But to complete a transfusion that has been, initially there was, but now it's not there because there will be a lot of vascular leakage and also we do not want to complete it, but we want to keep on evaluating. We have to
So
initiate it and
initiation
keep
of
on
the crystalloids
evaluating.
is in the first out bundle, but not to complete.
Please come, sir, please.
You got a face? Thank you, sir. Nice explanation.
So quickly moving to, so this is a 1 hour sepsis bundle. I will move to the next question. So a 72-year-old male with no cardiac history is admitted to hospital with a low-grade fever and weakness. So he has leukemia and is on chemotherapy. He suddenly develops palpitations and mild SOP. His ECG reveals a AF with fast ventricular response, respiratory rate of 20, BP 100/60, and a heart rate of 154 with a saturation of 98% room air. So what is the next step in our management? Yes, sir.
Patient is hemodynamically stable, so we can go with the amiodarone. Amiodarone. Yeah.
Thank you. Anyone else?
Sumaya,
Yes, actually I have to give him the opportunity because he has not tried.
IV procainamide. Emergent DC cardioversion can't be done because his vitals are stable. And amiodarone, he is on chemotherapy, we should better avoid it. And procainamide is an antiarrhythmic drug and it AF developed
since the patient is hemodynamically stable and the heart rate is 154, so we are going to control the rate, and then we are going to think about the arrhythmia. The answer would be 2.
So please come again. Yeah.
okay, but before that I'll need some explanation.
Yes,
so
sir.
why not DC cardioversion in this patient? Patient is unstable. And what about the other drugs? Like somebody has said, why not amiodarone? Right. Right, you are right. So this is a case of sepsis, and along with that there is atrial fibrillation, right? So whenever you get a case of sepsis with hypertension with atrial fibrillation, whatever you do, it is very difficult to control heart rate. Even if you do cardioversion, again patient will revert back to atrial fibrillation because of the ongoing sepsis. So our target, as you have said, is to reduce the heart rate. And for reduction of heart rate, as you have rightly said, it is better to use beta blocker or calcium channel blockers rather than using amiodarone and digoxin. Okay? So your answer is correct. In this case, we'll go for IV diltiazem or metoprolol. Thank you. Sumaya gets the prize again.
So, anyone who will try?
DC cardioversion, because the patient is unstable right now and he's getting drowsy, confused, heart rate. I mean, the BP has been already fallen, so we can't give amiodarone or metoprolol also. Exactly. So beta blocker is already ruled out. Amiodarone will reduce the blood pressure, and DC cardioversion, as he's already in 80/40 high fever, so the hemodynamics unstable. So DC cardioversion will be the option here.
Okay, your answer is right. Now we'll do the DC cardioversion now, because now he's hemodynamically unstable. So you have to try to do DC cardioversion, and then we'll decide next course of action. Okay, so
Thank you. Please come.
the prize goes to Arup.
We will move to question number 10. So O'Grady's classification is related to? Yes, sir. Acute liver failure. So can you just explain a bit?
Hyperacute, acute, and subacute. 0 to 7 days, 1 week is hyperacute, 1 to 4 week is acute, and greater than 4 week up to 12 week is subacute.
So this question is about this 46-year-old male diabetic patient admitted with severe SOB and altered mentation. His X-ray is as shown here. ABG showed type 1 respiratory failure with a PF ratio of 150. He was ventilated as per LTVV. Repeat ABG after 4 hours taken. So which of the following reports is permissible right now? Yes, yes.
Option B, PCO2 60, pH 7.253.
Thank you, sir. Please come. So, sir, do you want to say anything regarding this? Which of the following location is not a common location for hypertensive bleed? Please.
Cerebral cortex.
Cerebral cortex is the answer. Rightly said. The most common location? Yes. So the least common location is cerebral cortex. For a slide, take a look.
So the next one is, according to ACLS protocol, the reversible causes of cardiac arrest are all except. So please, sir.
Sorry? It's hypoglycemia. Or, sorry, reversible causes except hypoglycemia. Reversible, these are reversible causes. Oh, except. Hypothermia. Hypoglycemia is the correct answer, I think.
So there are 5H, 5T. So please come, sir.
Hypothermia, hypoxia, hyperkalemia, acidosis, ions, and hypovolemia.
So please come up. The right answer is hypoglycemia. Thank you. So which of the following conditions in ICU is not associated with hyponatremia?
Actually, nephrogenic diabetes insipidus will be having hypernatremia, not hyponatremia.
Thank you. Please come up.
So there will be more free water excretion.
So moving to question number 15 is, we all have 72-year-olds. Since all 5 patients we had were all 75-year-old. So this is another 72-year-old, was transferred from other hospital with a mixed respiratory failure and was immediately intubated and ventilated, started on vasopressors. Meropenem and ticoplanin was continued as it started just prior to the transfer. He was found to have bilateral consolidation and pleural effusion. At the time of intubation, the ET tube suction was taken and sent for biofire test, and this is the report. So this is the biofire report. I think we can see this. This is a Staph aureus detected,
From above, probably I can say there is E. coli 10 to the power 5, Klebsiella pneumoniae group more than 10 to the power 7, Serratia is more 10 to the power 4, Staph aureus 10 to the power 4. Or the resistance gene which was detected was MEC-A, CTXM, NDM, and OXA48.
NDM was detected. So I'd like to go to the previous slide once more. So he is now on meropenem and ticoplanin. So with this biofire report, so what is the choice of antimicrobials? I will give you the opportunity first.
It will be ceftazidime, avibactam, aztreonam plus ticoplanin.
So why? Can you please explain?
Because NDM it has detected, so we should give a combination of ceftazidime, avibactam with aztreonam. Combination therapy for MDM bug.
NDM. So why ceftazidime, avibactam is not efficient against NDM?
NDM.
So you have to use
aztreonam combination.
So what is for OXA48?
OXA48 means this thing, that class A, B, C, which one?
So the thing
OXA is class D of amla.
Act on OXA48. So what is the drug for
ceftazidime,
OXA48?
avibactam, that is.
Ceftazidime, avibactam. So you are using aztreonam only for NDM?
Only for NDM, combination therapy. What is
okay, that's true. Or for MRSA, ticoplanin. So what is about linezolid? Will you prefer linezolid in this case?
No, sir. It is for this thing, bloodstream infection. But not in bloodstream infection.
So probably we are dealing with sepsis because we have started on vasopressors. So we cannot just waste time using experimental drugs. So probably full coverage with aztreonam, full dose along with ceftazidime, avibactam. One thing I just have to underline that the 10 to the power 4 colony count is for Staph aureus and strep pneumonia and serratia. So probably those are colonizers. So among those things, Klebsiella is the most significant organism that probably causing this pneumonia. But we just can't exactly ignore about the Staph aureus because it is MRSA. So using ticoplanin may be optional, but we just can't at this point of time in our part of country where MRSA is not that very common in ICUs. Still, if we detect ICUs in hospital-acquired infection with MRSA, we must treat. So it's Klebsiella, KPC, NDM, and along with ticoplanin.
Okay, thank you, sir. So you get a prize. Please come.
The next one is an easy go. So not a diagnostic criteria for DKA. Yes, sir.
Blood glucose, more than normal diagnostic criteria is any history of type 2 diabetes or blood glucose more than 200. There's no blood glucose more than 250 per se. Other blood ketone more than 3 and serum bicarbonate less than 15 are included in diagnostic criteria.
What is your answer?
Not a diagnostic criteria, actually it is blood glucose more than 250.
Actually, the clue is anion gap because you have to, when you are talking about diabetic ketoacidosis, there has to be anion gap acidosis. So if anion gap is less than 10, doesn't fit into the diabetic ketoacidosis. So that's it. Okay, you get a prize. Thank you, Dr. Kiran, and thank you so much.
So this is question 17. This is a good one. So what is the most appropriate management for this patient who presents with fatigue and dyspnea? There is no option.
First, you do the diagnosis from ECG. Very careful. Let me finish. Very carefully see the ECG first. Do the diagnosis and then tell me the treatment.
I will like to go to someone who has not tried this time.
Electrical alterance. Electrical alterance. ECG. Pericardiocentesis.
Thank you. Thank you.
So it is electrical alternance probably due to the pericardial effusion. So probably the patient presents with fatigue and dyspnea. They may present with tamponade so far. So pericardiocentesis.
Dr. Babu.
So this is a 23-year-old female presenting with a post-elucius state, convulsion, hypotension by a cardiac arrest and post-resuscitation. On ventilation and vasopressus. After resuscitation, she became hemodynamically stable, but the sensorium remained E1 VTM1. I will go to the next slide. So this is the CT. Now, what can we infer from this and what is probably the diagnosis? Yes? Press. Okay. Yes, so I will give you another option.
Hypoxic encephalopathy. Hypoxic ischemic encephalopathy.
So exactly after the CT was done, we have opted for MRI and it showed hypoxic ischemic encephalopathy. Next slide. The classical hypointensity all over the cortex. After a state of cardiac arrest, probably it was the patient was transferred from other setup. So probably the resuscitation was not that efficient that led to the hypoxic ischemic damage of brain.
Thank you. Please come, sir. We have another Dr. Babu on stage probably. Yeah. So quickly moving to the penultimate question. So a 36-year-old man presenting with a 2-week history of fever, headache, drowsiness and photophobia. He was previously healthy and had a high-risk behavior. CT was normal. and a lumbar puncture was done for him and was found to have a raised pressure flow. So what is now in the next slide, this is the CSF picture.
Cell is 110.
Cell is 110, all lymphocytes, protein 4.7, ADA 34. So, ma'am.
Sir, it might be TB meningitis.
So, okay, ADA is definitely high, as you have said, but in TB, protein is 4.7. We expect a bit more.
Someone who has not tried.
Someone in the next slide.
Do you want to try? Cryptococcal meningitis. So, why do you think this is cryptococcal meningitis?
In the background of lymphocytic with a high risk behavior, and proteins are also a bit higher.
I would like to say that previous slide, the first thing is that fever, headache, drowsiness and photophobia. Photophobia is very classical of that disease. Second thing is that the patient had a high risk behavior. So probably it was not probably detected, patient may have some immunocompromised state. And the third one is that it was found to have a raised pressure of CSF. So in that disease, normal CSF opening pressure is very high. Sometimes we prescribe draining of 30 ml CSF for 3-4 days to reduce the CSF pressure. Next slide. So this is India ink preparation showing the encapsulated cryptococcus. So this is cryptococcal meningitis. The classical thing is that photophobia, extreme headache, immunocompromised status, and the most important thing is just increased CSF pressure. So this is cryptococcal meningitis.
Thank you.
And now comes the last question.
So the last question is, who am I? So I am a Dutch physician. So the next one. I was very good at physics. Finally, I used electrophysics for the sake of medicine. Yes?
Huh? William Ronjan. Ostler.
William Ronjan.
William Ronjan. Okay.
Okay. So we go to the
German.
I invented a thing long back in 1895 that is still valid and gold standard for managing some patients. Going to the next, yeah? Eindhoven. I am not very sure about the physics part. So, my invention became the routine of the modern medicine. So the next one. Anyone? So I'm going to the next clue. I was awarded Nobel Prize in the year 1924 for my invention. Yes, sir? Ready? What is the name? Who am I? So, who am I? Yeah. Curie. No. Curie was, yeah. Probably twice, yeah. Twice. So, here am I. Yeah, so I will. Yes, yes.
Christian ejectment?
No. Anyone?
Sorry?
Anyone else? Repeat the question, then I will have to go back 5 to 6 steps. Okay, which I can actually, because this is the last question. So I'm a Dutch physician. I was good at physics, finally used electrophysics for the sake of medicine, invented a very important thing in 1895, and it's still a gold standard, and my invention became a routine for modern medicine. And I was awarded Nobel Prize in the year 1924 for my invention, and here am I. Yes, sir? Eindhoven is already there in my list? Okay. So, yes, sir. Please.